I always like to use the analogy, it's very much like baking a cake, where if you're baking a cake at home, you can pull the box of Betty Crocker and mix it up and you have a cake. Well, compounding is very much like making that cake from scratch. So we actually measure out the sugar, measure out the flour, measure out every ingredient that goes into a dosage form and mix it together. So compounding is all about really making medicine uniquely for each individual patient to solve their specific problem.
Welcome, everyone. And today we have some special guests with us that are in the area of delivering services to hospice patients, specifically pharmacy services and equipment services. The guests we have with us are Q Oakley, a pharmacist and business professional with regard to pharmacy and compounding. And then we have Connor Oakley, who's with us to talk a little bit about equipment and supplying things that patients need during their hospice days. And last, we have Lauren Bosch, doctor of pharmacy, who is going to talk to us a little bit about pharmaceuticals in the service of our hospice patients. So I'm going to start this morning by talking with you and introducing these three. And what I would like each one of them to do is tell a little bit about their own personal story of their career and then how they got involved with hospice. I'm Dr. Kevin Park, and I've been a physician now for 33 years and been working with hospice for over 20 years, probably at least 10 to 15 with community health professionals, and it's one of the best things I do. Best things I do because it's service to my God and my fellow people on the planet, and I feel like this is a wonderful opportunity to help others. So thank you today for joining us. First, Q Oakley, nice to meet you today, and can you tell us a little bit about your story and how you got involved with hospice?
Sure. So I've been a pharmacist and business owner now for 31 years. Graduated from Ohio Northern University, so local, grew up in Ayersville and got married and now reside in Continental, so very local to the area. And we're honored to be able to partner with community health professionals and provide local care for patients during their last journey here on earth. And it's been very rewarding, to say the least, and we're blessed to be able to give that care to patients.
Would you say that your introduction to hospice was something that you got connected from another instructor or teacher, or you had some other inclination, some guidance, some dream that one day you would be helping those that are in the process of death and dying?
Actually, how we got started in hospice many years ago is when I was just getting started in compounding, I had many requests from hospice and home health that they needed help with patients to control their pain. And in pharmacy school, all we learned about were the regular prescriptions, but what hospice wanted was compounds. And they didn't really teach us that in college about how to compound. So I had a dear friend in Lima that taught me how to compound. And then we joined Professional Compounding Centers of America, and very quickly compounding became a passion and a love of mine because it was really being creative and thinking outside the box on how do we solve problems for patients. So we then started doing hospice compounding. But what really drove me to really want to be involved with hospice is the personal experience that I had with loved ones My husband's parents both passed away, and I had a dear aunt that also passed away. And the difference that hospice can make and the compounded medications can be the difference between a nice, peaceful, restful death versus a very agitated and hard on the loved one going through it, as well as the caregivers. And I had to be by my aunt's side during her death, and it was very, very difficult. And we didn't have those compounds that we have today. So by providing the compounds, it can really be a more restful, peaceful experience.
Appreciate that. That's helpful to know just what's happening during that process. And we're going to get to that a little bit more, and I'm going to ask you a few more questions about compounding. Dr. Bosch, what's your story, and how did you get involved in this process of helping the sick and the dying?
Sure. So I grew up very local here, over in Ottoville. Then I went to pharmacy school at Butler University, which is just north of the heart and downtown of Indianapolis. So that was a big change. Graduated from there in 2018, stayed in Indiana for a little bit, working over there, and then me and my husband decided we wanted to move back home. So I reached out to Q here and was just like, if you're ever looking for a pharmacist, I would love to, we just want to move back. So if you have any opportunities, that'd be great. And probably a few months later, that came to fruition. So came on with the Oakleys about 5.5 years ago now. So a couple years after that, then they took on services with CHP. And that was kind of my first real experience then with providing medications and compounds for hospice. Learned, like Q kind of alluded to, you don't really learn a lot about compounding in pharmacy school. It's very surface level. I think the craziest thing we did was compound some chapstick, just to kind of get your feet wet sort of thing. So learned a lot kind of just on the job under Q, and still learning a lot on the job and under Q. But it's been, as Q said, very rewarding. You do learn a lot with hospice and just kind of providing that care. It's just different than your regular retail where they're coming in, getting some blood pressure medications. You're talking end of life care, so it's a little softer. I mean, all pharmacy work is serious, but there's a different level of serious. You're caring for some very intense symptoms that come with end of life. So to kind of help the nurses navigate that and help the family navigate that, it's very rewarding.
Thank you for that. When I see you talk, I see your energy and your excitement about trying to help others, and that's really cool for me to see as a physician. So I appreciate that, and Q, I appreciate the compassion that you showed through your words about being introduced to hospice and your experience with your aunt. Those indelible kind of thoughts or impressions on our mind when we see loved ones die through hospice compels us to do more for those that we're connected with in the hospice care world. So appreciate that from both of you. Connor Oakley, how'd you get into this, and what's your role with regard to supplying needs, equipment, and other things to hospice patients?
Yeah, absolutely. We appreciate you having us here today. I grew up in the pharmacy space, have been in the pharmacy industry all my life. I started down the path of becoming a pharmacist and decided that I enjoyed the medical equipment end of our business more. I work in all aspects of our medical equipment, from hospital beds to concentrators to CPAP machines and walkers and wheelchairs. I really enjoy all the coordination of deliveries and working closely with the family to make sure we get a timely delivery. And I love the medical equipment side of the business.
That's cool.
Yeah.
So, what I hear just thinking about this is that what you do helps to improve activities of daily living and facilitates some quality aspect to their perhaps last 6 months or so. And how do the families respond to that, Connor?
Yeah, I think we're pretty proud of our delivery and response time. Naturally when someone needs medication or a hospital bed, it's something that they need very quickly. I think people are are very satisfied, I believe, with our delivery times, because there's, when someone needs the equipment or medications, they need it soon. So we like to coordinate closely and make sure that the caregiver or the patient's in the loop on when we'll be there, and they can expect us to be there.
That's awesome. I know as a provider, there's nothing that frustrates us that are, trying to provide health care to folks, particularly the hospice folks. Nothing more frustrating than to have a prolonged delay, and knowing what they need and getting it is, sometimes there's a space of logistics that causes some problems there. So we definitely appreciate your sense of responsibility with regard to that. So thank you.
Yeah.
Q, I want you to tell us, I think it's important for me as a physician just to know, obviously I was a chemistry major in college, but I have no concept of what actually is involved with compounding. I'm asking this from an educational standpoint, but then I'm going to ask you about, some of the not heartfelt controversy, but maybe just there's some skepticism out there about what's involved, and is this a real thing? And
Sure.
I'll let you take off with that.
So for the general audience out there that's not familiar with what compounding is, I always like to use the analogy, it's very much like baking a cake. We have Betty Crocker up on the shelf, where if you're baking a cake at home, you can pull the box of Betty Crocker and mix it up and you have a cake. Well, compounding is very much like making that cake from scratch. So we actually measure out the sugar, measure out the flour, measure out every ingredient that goes into a dosage form and mix it together. So basically it is making medicine, whether it be a topical cream or a suppository. We make lollipops, we make capsules, suspensions, but it's very measured, calculated out, and the ingredients are very specific to help solve individual problems. So compounding is all about really making medicine uniquely for each individual patient to solve their specific problem.
So when you're making up a mixture like that, hospice, it seems to be a unique category of medicine in that some of them reach a point where they can't take oral medicine. So how does compounding help with that? And give me some examples of topical, and then I'm gonna ask Lauren to talk about one specific one of those.
Sure.
Go ahead.
So at end of life, when patients lose their ability to swallow medicine, that's where compounding can really help facilitate either a sublingual liquid that can be put under the tongue or topical medications that can be applied topically to the skin, say to the wrist or the forehead where our skin is very thin, so that those medications can be absorbed in and into the bloodstream and be effective.
So if they're having trouble swallowing, how does that sublingual thing work? Mentally, I struggle with that a little bit too, because I'm ordering something and I'm afraid are they concentrated enough that they're small enough quantities that they're not making it down to their airway? How does that work, Q?
That's exactly correct. The dosage, the suspensions or liquids are very concentrated, so it only takes maybe a tenth or 0.25 of an ml under the tongue. So a very small quantity that gets absorbed in the vascular system under the tongue so that they don't have to swallow.
A 0.25 of an ml, that's a 1/20th of a teaspoon for those of people out there that don't know. That's a very small amount.
Absolutely.
So, yeah. Lauren, tell me what ABHR gel is. People in hospice care develop symptoms that are sometimes very difficult to manage, particularly when they can't take the oral medicines that we mentioned. So explain to me what ABHR gel is and what's in it and what's it used for.
Sure, absolutely. So ABHR gel is going to have 4 different ingredients. We have Ativan, Benadryl, Haldol, and Reglan. It's used a lot at end of life for really extreme nausea and vomiting that they're not getting under control very well. So it's very common. The hospice nurses are great. They'll call in and say, this is everything that they're on. They're taking this medication every 2 hours, this medication every 4 hours, this medication every 4 hours, this medication every 6 hours. And that's just a lot for a caregiver to keep straight. And, that's round the clock care that we're constantly getting a patient to take all of these to keep things under control, if it's even keeping it under control. So the hospice nurses, they're fantastic. They'll call in and say, what's next? Like, what else can we do? And very commonly, ABHR is a great next step. You only have to apply it every 4 hours. You're only applying 1 ml. You're not applying very much. It's absorbed very well, and it's very effective. So that has been something we're very proud to be able to offer to the hospice agencies, because it does just really take a load off of some of that care of the routine around the clock applying or administration of the medications. That's a lot for the patient. That's a lot for the family. When we can do this round the clock, maybe every 4 hours, we're getting more sleep, where the patient's able to rest a little bit better and have those symptoms under control. So ABHR is a fantastic thing for hospice agencies to be able to utilize.
The Ativan and Haldol parts, do they help with maybe agitation or anxiety, both?
Correct, yes. So yes, nausea and vomiting is a big one that we use it for, but also agitation, the anxiety, all of those medications, in different doses can help a lot of different things. And when we combine them, they kind of help a whole array of symptoms kind of at the same time.
It's helpful to have more things in our armamentarium when it comes to treating our hospice patients, both from a standpoint of them not being able to take oral, just their situation, they can become confused or they're in pain, and there's a process involved that we really don't totally understand. But the medicines help bring about some peace for them. So, and the families really appreciate that for sure. Connor, tell me about getting oxygen to people. What's that process like? There are standards that are involved in Medicare that they have to have, oxygen saturation less than 88%. So what kind of hoops do you have to get through to get people oxygen in this kind of situation, since it's a different category in hospice care? And tell me the process of what are these tanks and then the oxygen concentrator thing. Give us a little bit background there.
Yeah, sure. So when we're looking at just normal Medicare insurance coverage, someone has to be, their pulse ox levels have to be at 88% or below on room air to qualify through insurance coverage. The coverage with hospice care is a little bit different. If the nurses that are visiting believe it's needed, they can just simply order the oxygen through us at standard protocol, which is 2 to 4 liters. So the nurse will call in the order and we'll deliver the concentrator. Depending on if the nurse believes if portable tanks are needed or not, we'll deliver the portable tanks. We also offer portable oxygen concentrators, which are a little bit better than a normal tank. They're not wheeling around a big cart or having a tank and a bag on their shoulder. So we offer those as well. And I think at the end of the day, the oxygen just helps with the comfort of the patient, But the qualifications between hospice coverage and insurance are pretty different.
Yeah, sounds like it. Mm-hmm. So you mentioned liters. So explain to us a little bit about that, about liter flow, and what kind of apparatus do you put on the patient to help them receive that oxygen? Sure.
Yeah. So like I said, the liter flow for hospice is typically 2 to 4 liters per minute. Usually we'll hook the patient up with a nasal cannula at the 2 to 4 liters. We do have some high flow options as well, some oxygen masks if the patient can't tolerate the nasal cannula very well. But we typically will only do the oxygen mask at a much higher liter flow. We do have some machines that will go up to 10 liters per minute, so all depending on what the patient needs. But we've got some varieties of machines that we can get the patient whatever they need.
Right. So the nasal cannula thing, it's a couple of prongs on a tubing. It fits right into the 2 nose holes, right?
Correct.
And it allows the patient to be able to eat too, right? Mm-hmm. They can eat or drink with that on. do you find that it tends to be uncomfortable, or what's the current technology involved with that to make it more comfortable for the patient?
We provide what's called soft nasal cannulas. So they're much softer than what I would call the typical hospital cannula, which allows them to eat, and it doesn't agitate their face, when they have it around their ears and their cheek. That's all we provide unless it's requested to have a traditional cannula. The soft cannulas don't last quite as long, but at the end of the day, I think they're much more comfortable and much better for patient care.
That sounds great. I appreciate what you're doing to help people be more comfortable in that process. Q, I'm going to get back to you now, and I'm going to make it a little bit more introspective or controversial potentially and ask you a tough question. When we give morphine and Ativan, which is a typical combination that we give with hospice patients, does it expedite death? Does it make it faster? What's the thought process behind that?
I think that is a very, very controversial way to think about it. But in reality, end of life for many, many individuals, they do tend to be very anxious, and their breathing is very labored. So when we control their pain and help them with anxiety, it really just slows down and relaxes all of what we call the GABA receptors that cause anxiety, the glutamate. So it just relaxes them and really doesn't speed up the process, but can make the whole experience, again, very peaceful.
So there are opioids that do cause problems. Specifically, methadone prolongs QT. The QT is part of the EKG cycle that, if it's prolonged, can cause arrhythmias that cause death. But so, why do you think we've gone to a shorter-acting morphine combination for the most part with hospice?
I really think it's the way that morphine has the ability to slow down the respiratory rate and relax individuals.
Mm-hmm. And what if a patient, for some reason, is allergic to morphine? Morphine stops my breathing, so I cannot take that. What other options do we have?
Sure. So a lot of patients that are sensitive or allergic to morphine, we would use oftentimes Dilaudid.
Dilaudid has a kind of a street discussion and all that. Talk about that a little bit in this scenario.
Yeah, I think that any of the narcotics have street potential for abuse, and we oftentimes have to watch in the home sometimes for some caregivers misusing or taking some of the patient's medications. So it's always something that the nurses and pharmacy are watching out for, really for the best interest of the patient, so that the patient has the medication when they need it.
Okay. Let's look at conversions. So, and by that I mean pharmaceutical conversions. So when someone is in chronic pain, let's give an example, someone with prostate cancer with bony metastasis, and they've been on, say, Percocet 4 times a day, that kind of thing, for fairly severe pain. How do you convert a Percocet to a morphine dose if they suddenly are having trouble swallowing pills?
Yeah, so that's a great question. We have conversion charts. So when we look at moving patients over, maybe from one medication to another, or maybe their pain has been totally uncontrolled with oral dosage forms, and we want to or need to switch them to, say, a fentanyl patch, we can add up all the oral dosage forms, or the opposite, going from patch to oral. And we add them all into the calculator, and the calculator then tells us the amounts to transfer them over to, transition.
So the standard is a morphine equivalent, right?
Correct.
Okay. And certain drugs have higher morphine equivalent or higher concentration or intensity with regard to that? Fentanyl being a big one, right?
Big one, oxycodone being a big one.
Okay.
Yes.
All right. And other medicines like tramadol or Tylenol with codeine or hydrocodone with less multiplier when it comes to the morphine equivalent. Is that correct?
Absolutely. So a lot of times we'll work with the nurses and kind of brainstorm together to see what they've tried, what's worked, what's not worked, and really a lot of times, like in your patient that you gave the example to with bone metastases, sometimes it's a matter of getting on board maybe a special form of magnesium or getting them to sleep well, those types of adjunct therapies that can really help improve their sensitivity to pain.
Okay. Thinking about nutrition and that kind of thing, in a nursing home setting, we'll a lot of times have people on mirtazapine or Remeron, which is an antidepressant which stimulates appetite. What's your thoughts about that in a hospice role?
That's always tough because usually in a hospice patient, their natural progression is to lose their appetite. Mm-hmm. And we always want to help stimulate that, but I think it's really up to the family members and the patient,
right,
whether they want to pursue that or let God take his course and that transition.
Yes. I'm thinking about that process, and you mentioned the natural process. What, in a sense, are you doing? What are we doing together as a pharmacy and physician team? Are we trying to just ease the process, but not change the natural course of it?
I would agree, and really to improve the quality of life that these patients have left. Being on the other side many times as a caregiver and family, we never want to give up hope. And we want to keep pushing, and prolong our loved ones' lives. And really, they're in God's hands. And no matter what we do, we don't have that control.
It's good to know that you have some similar beliefs and understanding about God's providence in people's lives. I appreciate that. Mm-hmm. Thanks for sharing that. We'll shift gears here a little bit. And Connor, as far as mobility in the home, what kind of instruments or equipment do you have to help people with transitions to not being able to transfer as well and needing services that help them still have some mobility? Are things like bedside commodes, that kind of thing, are those available through your office?
Yeah, we carry lots of forms of mobility, like bedside commodes, wheelchairs, walkers. We provide some patient lifts and slings to help caregivers transfer, from a wheelchair to the hospital bed or onto the commode. Some rollators for a patient that's active or a standard walker, but lots of the wheelchairs and transport chairs. Transport chairs would be a lighter weight option of a wheelchair, but yes, those are all items that we provide and are available.
What's a Hoyer lift, and do you help people get those at times? That's kind of an extreme measure, isn't it?
Yeah, we do. We offer them. It's not something that we deliver very often, but we have them. Like I said, it's important if caregivers need help transferring a patient from a commode or a wheelchair back into the hospital bed, we would provide the Hoyer lift and sling.
That sounds excellent. I think we have the mindset that we're going to do whatever we can to help the patient in the process, which is really good. Q, speak to the teamwork that we have with you and the nurses and the communication. How does that work? Are they bothering you? Do they call you and say, Q, what can I do? That kind of thing. Talk to me a little bit about that.
Well, really, that's what we're there for, is to help the nurses solve each patient's challenges or to help make them more comfortable. So yes, we do get lots of calls, but that's kind of the beauty of the whole process, is working together as a team. And it takes a lot of coordination with our hospice groups, but at the end of the day, we're all there together to ultimately help the patients.
That's fantastic. I'm thinking about things and sitting here, and I'm also a coroner, and I know there's some legislation that's been introduced in the state of Ohio to potentially allow patients to be facilitated in their death, essentially euthanasia. And I know you have a different concept of that based on your pharmacy work here. Are we facilitating death, or are we just keeping people comfortable?
I really think we're keeping people comfortable. Back in the days of Kevorkian, if we're old enough to remember Kevorkian in the assisted suicides. But in our case, we're really keeping patients comfortable and improving their quality of life that they have remaining. That's
good to hear. I'm concerned about the whole concept of people taking things into their own hands, and it's very complicated from a legal standpoint. And what does a coroner do with those deaths? I have a hard time even fathoming how we explain that, how we fill out the death certificate. It's very complicated, and I hope we don't see it. There are states in the United States that do allow that, though I'm concerned about that. But let's stick to more positive things here today, discussing the use of pharmaceuticals and equipment to help the sick and the dying. Let's get to a couple of final questions here. Connor, what's your thought about just connecting with the patients themselves and their families? What do you see your role as you connect with them? Do you take the equipment yourself to their homes? How does that work?
Yeah, so I'm primarily in the office. I do deliver some as well, depending on the day. I really enjoy delivering, getting out of the office and delivering the equipment, setting up the equipment, because we're there to improve their quality of life, and sometimes they're not always happy to see that oxygen concentrator or that bedside commode. But like I said, we're there to help them and improve their quality of life. So I think they find it very beneficial. And the nice thing is our delivery drivers that deliver, they become on a name basis with the patient. The patient knows their name, and we've got a great team of drivers and staff in office that we connect pretty closely to the patients. It's a great thing. So
that sounds awesome. Appreciate that. I think our connection to the families in particular are super important. And Q, I want you to speak to that. Do you have any experiences with connecting with patients or their families with regard to the medications and what services you've provided?
Absolutely. Yeah, oftentimes with hospice care, our connection is more with the nurses than the families, because the nurses have to call and authorize or give their okay for us to refill medications. But at any time, patients or their caregivers are encouraged to call the pharmacy and ask any questions, or if they're having trouble, to give us a call, and we're always there for them.
That's good. That communication is really important to make sure we're getting the accurate amounts and timely delivery and all that kind of thing, because the nurses are on the pulse, if you will, of the patient, but also on the pulse of the situation, the general idea of how things are going. And sometimes it seems like there's escalation of pain with a rapidly aggressive tumor situation. What other things can you do for bony pain?
That's a great question, and I started down that path earlier. But oftentimes for bony pain, we really like, in pain in general that's kind of more uncontrolled in the hospice patient, we love to get patients on dexamethasone. to help those pain receptors and calm down all that inflammation. Works great for bony pain. But also we can make ibuprofen gel, and the reason the gel is maybe a more preferred route is that we don't have to worry so much about kidney function or ulcers that we would have to worry about with an oral tablet. So again, the world of compounding comes into play to help minimize side effects or potential side effects for patients.
One last question along that line, Q. We're talking about topicals. The ABHR has been modified so that it sometimes doesn't have, there's an agent that's controlled in that. Sometimes we take out a substance or because of nursing home care, there's some restrictions with regard to antipsychotic medicines. So we try to get rid of the Haldol in those situations. Talk about that.
Yeah, so we can make just ABR gel and leave out the Haldol. And in the nursing home or skilled nursing homes, they aren't able to have the antipsychotics on board or in the patient's regimen. So with compounding, we can, because we're measuring out each individual ingredient, we can leave that one out per request.
That's great. So we're about at the end of our podcast this morning, and we want to just give our panel here just a couple of minutes just in closing to talk about their relationship with CHP Hospice and their experiences overall. Give me just a few last words in summary of where you're at with your contribution and your sense of fulfillment along that role. Connor, can you speak to that first?
Yeah, sure. We're really grateful for the close partnership we have with CHP. We love that they are local, and so are we. And I think that together we can provide a really close, good care to the patients that need it. You know, the nurses are local, our drivers are local, so if it's something after hours, they're within quick reach to deliver whatever patients need. And I think, over the last several years, it's been a great partnership. So
that's good to hear. That's really good to hear. I've had that same experience with the professionals that are involved. Everybody working together as a team to deliver the best care we can every day we work for them. So thank you for that. And Q, what kind of closing comments and words do you have for us today with regard to that relationship?
Yeah, I think you both nailed it. It's really that teamwork and local partnership that enables us to provide great care to our patients in our communities, and we greatly value that partnership that we have with CHP, and a big shout out to the nurses because they literally are the glue that holds all of this together, and they're kind of our intermediate, right, to go between the doctor's office and the pharmacy and the patient and the medical equipment, and to just keep us all organized and ordered when the patients need it most. And it's just been a great partnership on our end to be part of CHP and to be a part of each patient and family's journey.
There's a lot said right there. Hard for me to follow that up, but I just want to say thank you to the panel members this morning, Dr. Lauren Bosch, who needed to step out, and Connor Oakley and Q Oakley. Dr. Kevin Park, a part of the hospice organization, CHP. And I'm going to close you with this. This has been a wonderful experience to just discuss maybe some tough questions at times about what we're doing in the process here. We're trying to care for patients. If you will, we're loving them as we can and know how to do as providers of healthcare. And we're trying to make their process more comfortable so that their families, loved ones that are watching this process cannot be distressed. And we're thankful that we can work together and try to do the common good, which is serve God and serve our patients. So thank you for all of you today. Have a great day. Peace out. Thank you.